Good morning, good afternoon, good evening, everyone. Welcome again to the second edition of the webinar series on data analytics and healthcare supply chain management. We are happy to have you again on this call. We are happy that you joined us for the first series, and then we had a good time with Philip presenting to us and Dr. Gladness presenting. Unfortunately, we didn't have enough time to exhaust all of the presentations, and Professor Andy could not even present at all. I know that we are all excited to hear what Professor Andy has for us, and if possible, we'll also accommodate Dr. Gloria in the complete the second part of her presentation. Well, as you all know, that supply chain of health commodities is what we all do, and the essence is for us to ensure that commodity gets to the last mile such that the clinicians and the clients can take advantage of it and get the therapeutic outcome that we all desire. As it said in supply chain, there are three major flows. There is a commodity flow, there is data flow, and there's money flow. And you know that data seems to be the central to either the flow of commodity or the flow of fund. And that's why we have paid a very close attention to the analytics of data and how we can use it to influence the management of health commodities. Well, data may not be too new. It may not be, the analytics even may not be too new, but with newer technologies, we know that we can take better advantage of data and deliver better quality of service, even to the people that we serve and within our organization. So it's my pleasure to welcome you all again to this platform to engage this topic with Prof leading the pack today. And then I encourage all of us to come up with our comments, questions, and contributions, because we will have sufficient time to interact and engage this topic sufficiently today. So it is my pleasure to welcome you. I can see Vanessa, welcome. So Prof, you may just want to say hi to everyone and let us know that you are here. Professor
Greetings to everyone. Yes, I'm certainly here and ready to go.
Thank you. Sonia, do you want to say hi to everyone and let us know that Empower is here too?
Yeah, hi everyone. Welcome you all.
Great. All right. Like we know, this is the objective. We want to make sure that we have the understanding of how data analytics in healthcare supply chain, and then we'll point out some case studies or case references and point us to the direction of development that can happen so that we can take advantage in implementation of logistics, the 6 Rs of logistics. Next slide. So we'll have a poll just like we had the last time. Next slide. We encourage you to take the poll effectively and let us know what you feel about the webinar. One of the poll is on now. Let's take a moment to take the poll. The first question is agenda. We want to know how close we are to the United Nations target of having gender equity or equality. Your age, so that we can also stratify the demography by age, your geographical location, where you calling in from. I can see majority here already. Africa, I can see Middle East, I can see Asia, I can see Australia and the Pacific, I can see Europe, I can see the Americas, and then yes, Africa is still leading the pack, followed by Middle East. Then what are your academic background? I see pharmacy and pharmacy related background. I see advanced degree and PhD. I see management, I see public health, I see engineering, logistics, and others. How many years of work experience do you have? I see that the majority of us for now have about 10 years experience. Yes, I can see that majority of us heard about this webinar from the email from Empower. Some the email from IAPHL, then the social media. Seems that the email carries the majority. Okay. We still have a couple of persons that have not attended it. About 135 had attended it. We have 225 or so on the call. So we expect at least we should have like 60% attending this poll. Yeah, once we get 60, we can move over to the next slide. Okay. All right, so we are moving on. It's my pleasure to introduce the speaker of the day, a very respected, well-respected veteran in public health and in supply chain before he eventually moved on to academics, and he had been very revered in the academic world. His name is Professor Andy Baracloy. He's a global public health expert. He's a professor of public health and director of capacity building at the Empower School of Health. Andy is one of the co-authors of the Yellow Book, Managing Drug Supplies by MSH and WHO, and the e-handbook of Health System in Action. He has over 30 years of experience of working with major international funding institutions, bilateral donors, and the private sector in low and medium income countries. The main focus of his experience include effective management of pharmaceuticals, vaccines, and medical consumables, and especially the implementation of programs for the introduction of new medicines and rapid diagnostic for neglected tropical diseases. He has undertaken donor-funded activities in over 40 countries, from provision of family planning commodities and the response to the early onset of HIV in the 1990s. Through the Global Fund grants in the 2000 essential medicine provision in conflict zones and extensive training in the quality of medicine. Most recently, he has authored the GOARN Supply Chains for Emergency Response COVID-19 Platform Pandemic Preparedness Training Modules and the Master Degree course at Empower. So it's my pleasure to have the lantern relinquished to Professor Andy Baracloy, the respected veteran in the space of public health and supply chain, and even in the academics, to take us through the next slides of presentation. Professor Andy, it's my pleasure to hand over to you, sir.
Greetings, and thank you for the introduction. Welcome to all. Good morning, good afternoon, good evening, wherever you are in the world. Okay, so we're going to look at data analytics in healthcare supply. I'll be the main speaker today. If Dr. Gladness is able to join us a little later, then I'll hand over to her to complete the session that she started last time. Next slide, please. I want to make the point that healthcare supply chain data analytics is not new. If we look back to the ancient papyri scrolls of Egypt and of even Queen Cleopatra 2,000 years ago, you will find data analytics of medical supplies, and also for the logistics of the Roman army. You will find data analytics for medical supplies of the Roman army 2,000 years ago. We wrote the first edition of Managing Drug Supply, the Yellow Book, in 1982. That include data analysis. So this is not a new topic that we're talking about. It's come to the fore now, it's come to the vogue largely because of all the chaos that was caused by COVID. And it's really brought home the need, the essential requirement for us to start managing data and to incorporate data analytics into healthcare supply chain. Next slide, please. The overall premise of my talk is that the public health procurement and supply chain in low and middle income countries is nearly dysfunctional. It's borderline operational. Yes, it's operating and it has been improving, but it's not keeping pace with the demand for the type and especially the volume. Over the last 15 years, we've seen a 4-fold increase in the volume of commodities. How many COVID test kits did you have to handle? Huge volume. How many malaria rapid tests, HIV rapid test kits, all the diagnostics that are going through, as well as the new medicines. And the point about these diagnostics is they're high bulk items. It's big volume. We're trying to manage massive volumes with a system that's not grown that much. We've got a little bit better, but it's not kept pace with the investments that have happened. More than 20 years ago, Bill and Melinda Gates Foundation started a massive investment in poverty-related neglected diseases, PRND. That investment is now producing products. They're coming off the product line, especially for rapid diagnostics. And that's massively increasing the volume. We're trying to handle these new products and these massive volumes with obsolete techniques, with little reliable data, and often even the concept of data in the public sector has been ridiculed. My point is, even in this environment, even with all these problems and challenges, it's still possible to utilize data analytics, and we should be using it to drive the improvements and to advocate and improve data collection so that we do get better. You can make a difference by advocating for supply chain data analytics, by recognizing its importance and by advocating to implement it. Next slide, please. If we look at the reality of public health supply chain in low and middle income countries, 2 million people, nearly 30% of the world, does not have access to essential medicines. It's a huge failure. It's not just a supply chain failure. There are many reasons, but the reality is there. We're not giving access to nearly a third of the world. And the donors feel they've invested massive amounts in health supply chain. It's not quite true. It's not all that much, but they feel they've invested massive amounts and they're not seeing any improvement, partly because the volumes have increased massively. You have actually improved, but you can't improve when you're continually doubling the volume that you're trying to handle. And it's not just infrastructure. The point around this, many countries don't have really good road networks. But if we look at those clinics and hospitals that are close to the central medical stores, they're often as much out of stock as the ones that are remote. We can't blame it on the country infrastructure. There are systemic failures in our health supply chain. That's the reality that we're having to face. Next slide, please. And these failures cost lives, what we call the delivery failure death rate. How many people are dying because we're not able to deliver the supplies? Even when we've got the money, even when we've got the medicines, even when we've got the health commodities, we're not getting them through to where they're needed. That's the reality. And the reality is people are dying, and there's different estimates of how many. We see 6 million, 10 million people are dying because of the failure to get those commodities to the patients. That's the reality of the systems that we're working with today. Next slide, please. And the biggest challenge in the supply chain, why are we failing? Well, often it's because no data. We don't have data. We don't know where the supplies are. Even when we have data, it's often in paper form, it's in a silo. It's not being shared. It's not moving around. The health centre is not reporting to district regularly. District is not reporting to province. Province is not reporting to centre. It's all locked up in paper. It's not electronic data, and it's in silos. This data is a massive challenge. We cannot undertake any form of modern management without current, accurate data. And the reality is, in the majority of our public health supply systems, we don't have it. The Partnership for Supply Chain Management rates it as the biggest challenge, data. Further, we don't have the processes to collect the data. We're not gathering the data to be able to undertake any analytics and realistic management. Next slide, please. Recently, during COVID, we did a survey of countries in Southeast Asia who were receiving COVID commodities to look at their supply chain information. So, how many had their stock out rate? How many had days of expiry rate damaged? Well, in fact, 75% didn't. Only 25% of countries could tell me what their fill rate was. When a district ordered, how much of the supplies did the district actually receive? 25% of countries out of 11 countries knew that. But stock out rate, out of stock, delivery time, transport capacity, what's the value of the stock in the warehouse? Don't know. No idea. Even the most basic data. And most of these are middle-income countries, don't know. It's not there. There is practically no one in the private sector that doesn't know these indicators to 3 decimal places. They wouldn't consider operating a health supply chain without this kind of key information. And we don't have it. So all the time, we're having to take decisions based largely on guesswork. We don't have good data. The little data we have is often incomplete and unreliable. Next slide, please. One of the concepts that we try to teach is called the economic order quantity. That is to calculate systematically the best quantity to order to get the best price. And that's a combination of the purchase price and the holding cost. How much does it cost me to have it in the warehouse? And it's quite a complicated formula, which is a square root. And this is very common in the private sector. Everyone will have this available at the touch of a button. Yet in the public sector, it's ridiculed because we'll never have the information. I don't know what the annual use is accurately. I don't know what my ordering cost is. I don't know what the procurement unit costs. I don't know what the warehouse cost is. I don't know how much it costs me to store items in the warehouse. So I can never make the calculation. It's the square root of a guess because I will never have the data. I think that's unduly pessimistic, but it shows that we've given up before we've started. This is a simple formula, very common in the private sector, to be able to calculate the economic order quantity. But we're not trained to undertake it because we've said we'll never have the data. Next slide, please. Point here is to recognize data analytics adds real value to healthcare supply chain management. We have lots of published evidence. It's genuine. It really works. Hospitals, clinics, typically 30% of their budget. For Global Fund, they reckon 50%. of their budget is commodities. By employing data analytics, we can bring savings of 20% quite easily in the management, because we reduce wastage, we reduce holding costs, we reduce costs all across the board by having data management, by having data analytics. But organizations are not using them. We can see 81% don't try to undertake data collection, which would enable data analytics to work, that we could manage our commodities better because we have the data. We know what we've got, where we've got, and when we've got it. That basic information too often is not there. Next slide, please. And because we're failing to collect this data and use data analytics, we're not analyzing our supply chain. We're not finding where the real problems are. All the time we're guessing. Well, we have a large expiry rate because we don't really know, because we haven't got the hard data. We're guessing what's causing it. And often we guess very well. I don't want to be disparaging of people. We've operated this way for more than 30 years. And those guesses are pretty good, but they're not as good as hard data and evidence. And we need to look at these critical paths. If we're going to transform our health systems, we have to identify where exactly the problems are and where exactly are the bottlenecks. And to do that, we need good data. And that means we need to be collecting that data. Next slide, please. Well, how can you possibly do any data science, any data analytics, if you haven't got any data? Doesn't make any sense. Well, my argument is that's not true. It's difficult, it's hard, but we can still use data analytics even when we don't have good data, and we can set about starting to collect data so that we will have hard data in the future. It's not necessary to be perfect. We can start now with information, and I'm going to explain next how we do that. So although I've painted quite a pessimistic picture, the message I want to bring is of optimism. We can do things, and I'm going to give you some examples of what we can do now. Next slide, please. So we're going to use a multi-pronged approach. First one is to recognize the value of data analytics and to advocate. We must have data analytics. It's necessary. We've got to have it. Then we start with what we call little data, sample surveys, proxy data, data taken from similar systems in other places. And we develop models and algorithms. And then as we expand data collection, we improve those models, and eventually we change to using our own data. We have to do systematic strengthening. To do that, we use a system called theory of change, where we instill, we scale, and then we sustain the development. And we can do technology leapfrogging. We don't have to go through all the development phases that other countries went through. We can go straight to digital data, automated collection and analysis. Simple example is barcodes. Why aren't we using barcodes in our warehouse? Why is everything still on paper? It's a simple one. What about radio frequency identification? Scan straight away. Small corner shops, small retail pharmacies are using barcode and scanning. Surely, in our million-dollar public sector operations, we can embrace digital technology as well. Next slide, please. Okay, you want to go back one, I think? Yeah. Okay, let's just stay on the evidence. Again, there is clear evidence that data analytics works. On the screen now, how to go about it, and look at data strategies. It doesn't mean we have to do everything all at once. We start with a greenfield state, no utilization of data, and we slowly advance through early digitization, emerging, advanced analytics, and then the future state of digitization. The point is we can start now with early digitization. We don't have to leap straight in at the top and say it's impossible. We can do little bits. We can start getting familiar with data collection and data analytics now. That's the key message I want to bring. Get started. Next slide, please. We need 4 factors in order to help develop data analytics. We need stakeholder commitment to change to collect data. We need a clear roadmap that tells us where we're going. We need capacity building. And we need data visibility. We have to have data and we have to be able to see it. Earlier, I talked about these silos where data is kept in one place, it's not shared. We need to be able to share data across all the system where it's needed. We'll have to take these actions. We need strong leadership to help implement these actions. Next slide, please. Data analytics is recognized by donors, and donors will fund activities around data analytics. The most strongest example is PEPFAR. They insisted from the beginning on absolute data collection, and they used data analytics from the beginning. And they used predictive analytics. How much using the data to forecast and analyze the future, not just commodity forecasting, but more generalized forecasting. And we've seen the success of the PEPFAR programs in ensuring commodity supply. Massive scale-ups, massive from the early days, in diagnostics especially. That was possible because they insisted from the beginning on absolute data collection and strong data analytics. It really does bring benefits. Next slide, please. We can start with little data. By little data means we do a small survey. We just collect how is that going on. And then we build models and do what-if scenarios around that. So what would be the effect if there were more roads? What would be the effect if I used larger capacitor vehicles for deliveries? What would be the effect if I used more vehicles for deliveries? How would that strengthen my supply chain? I can do a small survey in one little area using 3 or 4 trucks, and I can model what is happening. So I can do the what ifs. If I did this, how is that we can improve? These examples are taken from Jos in Nigeria. The links are on the screen to the detailed publications. The point around that is I don't need massive collections of big data. I can start with small surveys, small collections of data, undertake modeling, and then extrapolate from the models. That's part of data analytics. Next slide, please. Another example of little data is proxy data. If I take the example of COVID, there was no data. It didn't exist. We hadn't had COVID before. What did we need? Nobody knows, because it's all new. So how can I have any data? Well, I can have proxy data. So what we did is we took some basic information from World Bank databases on population, on the healthcare parameters, how many beds, how many doctors, storage facilities in the supply chain, and then modeled from SARS and avian influenza and similar epidemics, made a model and used proxy data, used data from SARS to populate that model to develop the essential supplies forecasting tool for COVID-19 commodities. Delphic team developed those algorithms, and they changed over time. Many of you may have used the essential supplied forecasting tool on COVID commodities from WHO. Next slide, please. It's an Excel-based system on the screen now, and all the COVID supplies, not just the PPE, the personal protection equipment, but there's an example diagram of everything that was included on it, but also the medicines, the diagnostics, everything that's required in the essential supplied forecasting tool was based on algorithms on proxy data extracted from SARS and avian influenza outbreaks. So we can use proxy data. We can use data from other sources. Next slide, please. Lots of points are coming together. International transport was still a major problem. We had a massive scale up on COVID and COVID vaccines to overcome, 10 times greater volumes than we were used to, massive amounts of commodities. So it was a real challenge to get that volume of commodities. Many factors involved, but we could at least calculate how much was required. Next slide, please. And different parts of the tool linked with the emergency global supplies catalog, so you could see exactly what it was. It included medical equipment, oxygen supplies, ventilators. It included medicines, okay, personal protective equipment, and the diagnostics, all based on proxy data and modeling algorithms. Next slide, please. Well, did it work? Well, it worked reasonably well. The point around this is we didn't just stay on proxy data. We started collecting data. So in March, that was all proxy data. By January of the following year, we didn't need the proxy data. We had collected real data. We could now populate the model with real data. It improved over time. We can start using proxy data across our supply chain, and by collecting data, then slowly improve like that. We can go step by step. We don't have to say, I haven't got any data, I can't do anything. We can start small and collect and develop data as we progress. Next slide, please. How do we get this? Well, we use the human resources theory of change, which is quite a complex technology. There's a video link on the screen which explains how you go about implementing with the staffing and the skills, the working conditions, and the motivations needed to get people involved in data analytics and undertaking this kind of work I'm describing. Next slide, please. And how do we go through? We start by instilling, we start small, little bit of proxy data. We then look to scale by collecting data, and then eventually we go to sustaining it. In order to bring about this change, to use data analytics, we have to build trust. People are going to start to believe what we're doing. We have to have the knowledge and the skills. We have to have incentives and the structures and the resources and the systems and the policy. All of that's needed to be able to implement it. But we can start small, little bit of proxy data, one particular area, and see how we move from there. Next, please. How do we make it work? Small pilot, move to scale, then move to practice implementation. I'm sure you're all familiar with that kind of development. Yeah, it can go on now to next slide, please. Yeah. Okay, we often talk about supply chain 4 and people dismiss it. Well, that's never coming to my country. We're a low-income country. We're never going to have that. People do not understand key points when we talk about supply chain 4. Supply chain 4 automatically collects data. The point about drone delivery is not drone delivery. It's only ever going to be small volumes. That's not going to be the bulk of our operation. It can be useful for emergency supplies, The point about drone delivery is it automatically collects complete 100% data. I have everything on the computer, exactly what was delivered, where, when, and how. I can't say that for my bulk supplies. The point around this supply chain 4 is automatic data collection, all the way through, from the radio frequency tracking of trucks and supplies, barcoding, scanning, everything through. It is the data that drives supply chain 4. That's what makes it happen. And that's the advancement that's happened in the private sector, which regrettably has largely passed us by in the public sector. Next slide, please.
Thank you. Thank you, Prof. You may want to help us draw the curtain in another 3 minutes.
Right, I'm just about finished. Okay. So what's the problem? If there's so many success stories, well, they're all small scale. We haven't yet got to the tipping point where it's moved. I'm hoping that you will be the ones to drive that forward. Next slide, please. Now, please go and change the world and make data analytics work. Okay, I'm done.
All right. Thank you very much, Prof. Let us show some love from the chat group for Prof. I was totally taken by this presentation. He took us first to the laying down to the fact that we are not doing well enough. And he told us that this is not a prophecy of doom, that there are chances. I like the idea of using proxy data to achieve small scale and then eventually scale. Thank you, Prof, for sharing such an enormous wealth of knowledge with us today. Professor Dr. Gladys is here, and we would like to have her for a couple of minutes. But you, Prof, you may need to check the chat box. There's so much love going up for you there. We can take that to the bank after this webinar. Okay, so before I give the floor to Dr. Gladys, I will just use the next 5 minutes to entertain questions, the one that we can attend to by a voice call before we let Prof go. I have Mulenga hand up. Mulenga, you can mute yourself now and talk to us.
Absolutely. How are you all?
We are doing good, thank you.
What the professor has mentioned is actually what we were able to implement in South Sudan in 2010. South Sudan, the health systems there, I'm sure you knew, around 2010 were literally non-existent. So basically, we did not have data, what he was talking about. So we're using proxy data from World Health Organization or different other organizations for us to manage the supply chain for the HIV and AIDS commodities. And another thing that I picked from the professor was the essence of using the barcode, as well as tracking the commodities to where they are. So we were able to use the barcode and link the barcode from our central medical stores to the facilities that were receiving the medicines. So each time they subtracted, we would obviously see. Then another thing that we did, we encouraged what we call last mile. So we trained people to deliver the medications to the necessary people in good time, and it worked perfectly well. But before starting everything, we needed to identify persons that we brought to Juba to actually do, you're laughing at that, yes, Juba. So we actually simulated the whole supply chain for 2 weeks. We simulated, meaning wherever they came from, it was like it was their clinic. And then we went through the whole supply chain for 2 weeks. And after that, we gave them a package depending on how big they were, and we followed them up. It worked very well.
Thank you
But
very
for
much,
two,
Mulenga.
for
Thank
2
you.
weeks, the important thing is let's put this into training. Let's train people physically. You know, when we train physically, we're training those people physically in South Sudan because we brought them in and they were drawing from the warehouse, our warehouse, in the little corners in the hall where they were. Those were their own clinics.
Thank you.
So
Thank you.
we extrapolated the time to indicate when they can reorder and all such things. It worked very well.
I really appreciate
And
you bringing this case
the
scenario.
professor mentioned management sciences for health. Management sciences for health, I worked with them in Namibia, and we piloted the antiretroviral for the SADC region. So many things that he has spoken are things that we also had to use. We had no data, all sorts of things. But the handbook, the yellow book, is actually a good book anyone can refer to. I don't know why it seems to be everlasting. Thank you so much.
Thank
I
you.
appreciate
Thank you.
it.
Thank you
I
very much,
appreciate for
Mulenga.
giving me this time. Yeah.
Yeah.
So barcoding for all our products.
We have to let you go now so that we can entertain the other ones.
Yes, but barcoding for all our products as well as insurance is important.
Thank you. Thank you very much. I really appreciate it. I had some hands up. Unfortunately, I think they're down. Sonia, can you see the hands up again? About 2 hands. Okay, Arebu. Yes, Arebu Bilal. And one other person. We'll just give room for Arebu and Mohammed. But I just want to make the note that this presentation will be shared to us individually, and it will also be shared on the IAPHL listserv. So questions that are not answered here can be asked on the listserv. Professor Andy is on the listserv, who will be able to attend to this question directly on the listserv, and some other experts like Mulenga, who had a case representation of what has been presented, can address these questions on the listserv. So I encourage all of us to come up to the listserv and ask the questions and we'll attend to it. Yes, Arebo.
Okay, thank you. I am Arebo
Arebo,
from
Mohammed, you want to give room to Arebo Bilal first, then you can speak after him.
Okay, thank you. Can I continue?
You can continue now. You have only a minute.
Okay, thank you for the presentation. I really appreciate Professor Andy, very experienced person. We have been also using the yellow book while we were in school. And most of the issues that is raised is we share it in Africa, especially in Ethiopia. We do have a problem of data analytics. Not only that, we also share there is a problem in the capacity building of our professional. For example, I am a PhD student. I have been doing on forecasting and I have been trying to use the machine learning and different software. However, there is a problem of support because no one knows about this issue, especially in our country. And my question is for Professor Andy, how can we bring such kinds of knowledge and trainer towards the country so that we can be able to utilize this information and technologies for our supply chain management? The other question that I have or reflection is, as you have said, there are data that is collected on paper-based, and how can we try to change this practice into an electronic form so that we can be able to make the data visibility in a great place so that everyone can use it for forecasting and for procurement of health supply chain. So I have so many questions, but due to the interest of time, I have to stop here. I really appreciate the presentation. It's very informative, and we need such kinds of presentation again and again if it is possible, so that we can learn a lot from such kinds of professionalism. And thank you for the organizer also.
Thank you, Arebo. Please feel free to share the remaining question on LISEF. I appreciate your very astute use of time. Thank you. Okay, Prof, I will still hold you on for now. Let us listen to Mohammed so that I can take them all at once. Mohammed.
Yes, thank you, sir. I would also like to begin by congratulating and thanking Prof for a wonderful presentation. Quickly, I will want Prof to highlight to us some of the possible downsides of using the small data and the proxy data, because I believe that there may be some downsides of it which we may go into it and at the end not knowing that some problems might arise. So is there any possible challenges with regards to employing small data or proxy data, as the case may be? Thank you.
Thank you, Mohammed. All right, Prof, I will yield the floor to you so that you can quickly respond in 2 minutes, and then we'll move over to the next.
Right.
No,
Okay.
I'll give you 3 minutes, Prof.
Okay. Okay. Downsides, yes, there are. I mean, I used proxy data in Vietnam for opportunistic infections for HIV. The only data we had was from the United States. And I used it from a high-income country to model in a medium-income country, and it was not successful. It was better than nothing, was better than guessing, but it wasn't very good. So we very quickly changed over to using local data. We collected data from the start. So it didn't go well. Going from a high-income country to a low-income country rarely works very well. That's part of the downside. Sometimes, like COVID, you don't have a choice. We didn't have any other sources of data. That's what we had to use. And it was the same when opportunistic infections came along with HIV. We didn't have a choice. We had to use that. So that's the potential downside. It's not very accurate if you use high-income data. Okay. You asked me, how can you bring data analytics to our country? Empower, of course, is developing a new course just for data analytics, coming soon to a webinar near you. A full course on data analytics. How can you change from paper-based? Advocate. It saves money. It is cost effective. Advocate all the time. Start with barcoding and move on from there. Go to automated data collection because it's cheaper. It really does save money and it brings visibility on the data. Okay, that's enough from me. I'll stop there.
Thank you, Prof. Thank you. We can't exhaust all the things that we want to ask you on this call. We'll definitely find time to, like some of the people have just now because of time. But I will want to crave your indulgence to stay put here with us because Dr. Gladness had a meeting earlier, but she has joined us now. And then we'll yield the floor to her to engage us in the next 10 minutes. So you will be here till 20 minutes past the hour. So please, I will employ us to stay on the call and hear from Dr. Gladness. If you were here the last time, you will see the energy and the content that Dr. Gladness presented with. So I will quickly introduce her and let her take the floor. Dr. Gladness Ladislaw Salema is a senior lecturer. She's a senior lecturer in the University of Dar es Salaam Business School. She has 17 years of work experience teaching, researching, and consulting. She is a public health logistician with PhD in logistics and master's in public health. She has been teaching in the areas of operations management, managerial economics, and supply chain management. She has also conducted several research in health supply chain. Moreover, Gladness has consulted with both the public sector, the private sector, research institutes such as Research for Poverty Alleviation, as well as international organizations such as UNDP, UNFPA. She was the member of the 2017 Holistic Review of the Health Supply Chain of Tanzania, which has led to the redesign of the health commodities supply chain in the country. Ladies and gentlemen, permit me to welcome Dr. Gladness for the next 10 minutes. Dr. Gladness, it's over to you.
Thank you so much, Timmy. Can you hear me? Hello?
Yes, I can hear you, Dr. Gladness, loud and clear.
Okay, thank you. Once again, I want to thank the organizers for this important session. Thank you, Professor Andy, always very informative. So we learned a lot from your presentation, and I'll continue and see what we can cover in the few minutes that we have. But ideally, we are continuing with the discussion on what we are trying to emphasize is the importance of going beyond just collecting data. That is, as supply chain experts, we should be able to work on the data. What we are trying to say is that we have to find a way to digest this data so that it can give us some meaningful outputs, which we can use for our decision making. And that is a very challenging situation. As of now, we have a lot of systems that we have invested in the supply chains to collect the data, but data use is still a challenge. So this is in support with Sondergaard, who said that an oil of the 21st century supply chain is the information or the data. But we need to have analytics so that we can be able to combust this oil to give energy which can move the engine. That is the energy to move our supply chains to the expected outcome. So this is what is very critical here, that we are trying to work on the data. Next. So as said before, is that in the healthcare supply chain is that it's different from the other supply chains, because in this supply chain, we have multiple systems which are collecting data. We have the clinicals, but we also have the operational in terms of the supply chain data. But what we are trying to say, in order to be able to make decisions or meaningful output which informs the healthcare systems, then we must find a way to which these two types or the different types of data that we have are actually communicating or are actually interacting, so that we can have a clear understanding about what is happening in our health systems. But also in the health supply chains, we have multiple stakeholders, right? Yeah, you have different players, you have the suppliers, you have different types of health facilities, but we have the government, we have donors. So having multiple stakeholders is that it's also making it more complex, and all of them develop or collect some data, or they require some data, because they're also making different decisions, and some of the decisions are quite independent. So what is very important to understand is that if we don't have proper ways of making sure that this data, all this data that is collected, is actually analyzed in a proper way to inform even policymakers, end up with goal conflicts. That is, sometimes policymakers might talk of efficiency while supply chain experts that talk about effectiveness. So what we are trying to say is that having multiple stakeholders, if we want to make sure that they are aligned, we can never ignore the issue of having the data which is around, the data which is collected to be analyzed. But also what we can say generally is that having this multiple system, it means none of the systems is complete. Each system depends on another system in terms of different sets of data. So that's why we say we need to aggregate the data. We need to have a central way where we can work with data and we can transform it into meaningful output. So that is what is the essence of this discussion. Next. So what is data analytics? Yeah, you can just type in the chat box what is data analytics the way you understand. But basically, when we talk about when we talk about data analytics, basically we are talking about discovery. This is about discovering meaningful patterns, that something is hidden inside the numericals. Something is hidden inside what we collect as narratives. So we want to make it to put it in a way that it will be meaningful. So it entails the collection of the raw data. It means this is just data which has not been processed. These are just statistics. These are just parameters. But by themselves, you can never make any decision. You can never understand what is happening. So from that raw data, we need to prepare it, but then we need to analyze, trying to get an understanding or drawing out certain patterns, drawing out certain understanding about the parameters, about the statistics that we have. So that is basically what we are trying to say is data analytics. And at the end of the day, there must be value addition from the outcomes that we generate from this data. So it's about the collection, the extraction of data from different systems, but we also need to transform this data so that we can be able to have a common understanding. The transformation is also about the metrics which have been used to measure this particular data. For example, in some cases, you might have, let's say, if we talk about stock, you can have stock which is being measured in terms maybe in number of boxes, but sometimes the stock is in terms of number of bottles. So at the end of the day, we need to have a common measurement. And this is where we are talking about transformation. Or maybe we have very qualitative data, very narrative, then we need to code them so that we can be able to have a meaningful interpretation. So we need to transform this data. And after the transformation, the next is that we need to run this statistical analysis. So it could be descriptive, but it could be also cause-effective relationships. And all of them, we can do them using statistical tools. Yeah, we have both statistical tools for qualitative data, and you also have statistical tools for quantitative data. But just analyzing them is not enough. You need to synthesize, use theory, use the existing knowledge to explain what you see as output from your data, from your statistical analysis. So, and this is what we call interpretation. That is bringing the statistics to explain the practical issues that we are actually facing in our supply chains. And then for it to be useful, we will need to report. So you also report based on the needs of the stakeholders, which needs that report, but also you report in the manner that is required at different levels of a particular supply chain. So talk about the statistics, we talk about this description, but at the end of the day is that we are changing what we see as a raw data, raw information into a meaningful output. Next. Next. So generally we have two types of data. We have qualitative data. We say these are mainly verbal or narratives. Yeah, and at the end of the day, you need to analyze them so that you can have some understanding. So usually what is happening with qualitative data, the most easy analysis is that you are trying to group the data into similar patterns. And then when you get these patterns, they give you conclusions about the situation that you are observing. So the qualitative data can be collected, let's say through focus group discussions, like you have a group of practitioners, a group of clients, and then from their discussion based on the questions that you want to understand from their feedback, then you'll be able to categorize this feedback into meaningful patterns and the ones that you can be able to make some conclusions. But also you can use interviews, you can use open-ended questionnaires, to be able to capture their information. So usually with qualitative is that the problem or the issue that you want to understand is not very clear. So you want to go deeper into getting explanations. So that is different from the quantitative data. The quantitative data is that we understand that something is happening and we know how to measure it. So we use numerical terms to measure the values or to measure the variables that are of interest. But what is very important is that to understand is that we have different methods of analyzing qualitative and quantitative data, but we have also softwares which can do this analysis. And maybe you can, if you're interested, you can try to probe, the SPSS, the NVivo, and all these kind of softwares. But what is key is that in most cases in supply chain systems that we are collecting quantitative data. So it's very important that we understand that is there are different types of quantitative data. You have what are called nominal data, that this is just labels like or names that you give to the items that you have. But we also have what are called ordinal, yeah, and this is when you have a sequence or an order, let's say, where you have 1, 2, 3, you know, but the interval in the real sense is quite irrelevant. But you are just using them, you're just using the numericals to code the perception, to code the qualities that you want to understand. But we also have interval data, of which here we say the difference between, let's say, 1, 2, and 3 is meaningful. And then we have the ratio data, and here is basically that we are considering the properties of both interval, and that is in this situation, yeah, it's very absolute. Let's say if you're measuring temperature, you just know that the centigrades and all these kind of things. So what I'm trying to say is that if we talk about data analysis, we must understand that we have different types of data. So every time you must go down and understand what type of data do you have, because even in the analysis, even in the methods of collecting this data will be different. Yeah, we have different methods for different types of data. Next. Next. For the sake of time, next. So maybe it's also important that we understand that there are different categories of data analytics. We have descriptive analytics, we have diagnostic analytics, and we have predictive analytics and prescriptive analytics. These are the 4 common types, yeah? And ideally, each type of analytic has its own specific question that you want to understand. You know, if there's something that is happening in a supply chain and you want to know what has happened in that particular supply chain, we say you are going to have a description of what has happened, okay? So you collect data to provide just a description, you know, and mainly here you are using the historical information, you are using the past data, you know, the maybe the past previous stock levels and so forth to explain what has happened currently. But also we have what are called diagnostics, okay? So diagnostics basically is that you are going beyond describing. You want to understand why something has happened. So from the descriptive, you might be using just quantitative information, let's say, which shows the stock out levels and so forth. So in the diagnostic, you go deeper into understanding why you are observing what you observe. Let's say if you're observing a stock out, and then you want to understand why you have stockouts, then we say you are doing a diagnostic analysis. And in this situation, in most cases, we'll have to combine both the qualitative and the quantitative perspectives, because you always have a question why something's happened. So maybe you need to consult, you need to ask the expert, why are we experiencing the stockout? So they'll have to explain. So the moment they explain, it means we are going in depth into understanding the causes of what you have described. So that is what is diagnostic. But we also have what are called predictive. Yeah, and basically here is about you are using the data, you are using the parameters that you have to talk about the future, to tell about the future. So all the forecasting models, you know, and regression models and all those predictive analytics, those are what we call predictive, because they will tell you what could happen, you know, in the future. But you also have what are called prescriptive, is that it is trying to answer the question as what should we do in the future. So basically, when we talk about analytics, we are looking, there is a past ideal situation, but we also have the future ideal situation. So in terms of development, in most cases, most of the supply chains, particularly in developing countries, they end up with the descriptive. That is, you have the parameters, you have the data which is telling what is happening, okay, what has happened in the past. Yeah, and then we going further into an in-depth understanding about the why, the cause effects relationship between what you observe has happened is another step of growth or maturity in data analytics. So as you see, the 4 are organized is that it's about the maturity now. It will demand more expertise. It will demand more tools, more sophisticated tools to conduct such analytics. So the basic is the descriptive, but then we want to go further into diagnostic. We want to go further into predictive, do the quantification of the medical commodities, tell about the future expected consumption rates and so forth. And then we also want to prescribe this ideal supply chain that we want. If, let's say, we want to have a service level in terms of availability of medical commodities, let's say by 90%, that's what we want. So we can simulate our supply chains to be able to see how can we achieve such a service level. So that is a prescriptive. That is the imaginary future of what we want to do. Next.
All right, Dr. Gladys, you may want to round up in 2 minutes.
Okay, so maybe we can just see this as a roadmap towards our analytics. And as you see, there are several steps, and what I can say is not that it's so systematic. Sometimes you can go up to step 3, you can come back. But what is very important is to understand that the first thing is that when you talk about data analysis, you must have the question. What is the key question that you want to answer? What is this a topical issue that you want to address? Who is interested? Whose interest is there? Because we have understood that we have multiple stakeholders. So we want to know whose interest is that, so that we can be able to conduct a proper data analytics, because the outputs that are needed by different stakeholders are actually different. So when we understand the problem, then we will be able to establish what type of data do we need? Like, what parameters do we need? Do we need stock levels? Do we need to know the lead times? What do we need? What type of data do we need? So that it can answer the question that we have in step number 1. But then the next step is to retrieve the data. So we must understand what are the different sources of data that we have, what systems have this data, or do we need to collect the data like using surveys, interviews, and so forth, and then we have to have this data collected, or we can retrieve it from the systems. But after we retrieve, we need to transform this data. As I said, sometimes data is being stored for different uses, so even the parameters or the measurements are quite different. So we need to transform so that we can have common measurements. And when we transform the data, usually we must clean, we must clean, because sometimes data is not, a raw data is not yet suitable for using in statistical analysis. So based on the requirements of different statistical tools, you need to clean the data, and after you clean, that's where you can do your analysis, by using appropriate tools, or I can say appropriate softwares or appropriate methods. And it's very important when we do the analysis, next is that we should be able to have an interpretation, And here it's very important. When we interpret, we don't just use the data that we are seeing. We don't just use the output that we are seeing. We should be able to reflect the best practices in health commodity supply chain management. We should be able to reflect, what are the global trends when we are doing our interpretation. But also, we should never forget to understand what is the historical patterns, so that we can be able to understand how we can have recommendations for continuous improvement. So the next thing that is very important is that we need to have a way in which we can ensure that the data is visualized, okay? And here we are talking about using visualization tools, for example, data in charts and so forth. All of this is to ensure that this data is easily visible, is easily visualized, and someone can easily understand, like pie charts and so forth. And what is also very important is that when we are doing all this, at the end of the day, we'll have a report, but it's very important to validate the report, that you take it back to the people who gave you the data to make sure that the opinions that you have included are the correct opinions. And this is very key before you do any dissemination, before you share your reports to any the stakeholders. Yeah, so
Thank
this
you
is
very
briefly,
much. Thank you
what
very
is the
much.
roadmap. Yeah.
Thank you very much, Dr. Gladys. You gave us the first time, and again, you are giving us again. And time is still not on our side. I'm sure we have not exhausted the slides, but unfortunately, we had to stop at this moment so that some people could ask some questions. Or we have just about 5 minutes left, and I will not be able to entertain voice questions, but I have a lot of questions on the chat already. I can see some people showing Dr. Gladys some love already. So Dr. Gladys, check the chat box. People have been appreciating you and saying that they want these slides and all. So I have seen one question for Dr. Gladys around what are the available tools for data analytics. And then I saw another related questions. How do we leverage technology to enhance data analytics in health supply chain? Dr. Gladys, you may want to respond, and Dr. Andy, you may want to respond too. Gladys first.
Okay. Can you come up with the first question? I got clearly the second one.
Yeah, the first question says, what are the available tools? Example of available tools for data analytics. That came from Mohammed Abubakar. I have scrolled off, but it's there on the chart.
Okay, thank you. I think there are so many tools which are available depending on the research question. Also, depending on the question that you want to answer. For example, I can say basically we should never ignore Excel. Can you hear me?
Yeah, loud and clear.
Yeah, because Excel is available to, I think it's commonly available, but there is basic Excel and there's advanced Excel. So there are so many analytics which you can do using Excel. And depending now on the sophistication of your question, depending on the sophistication or the complexity of your problem, then maybe you need also more advanced tools. So basically, you can use for descriptive, you can just use your Excel. You can go further to SPSS. You can use the smart PLS, and for qualitative, you can do the in vivos SQL. So there are multiple softwares or tools that we can use. So it's different between tools and the techniques. It's quite different. So we need to understand, based on the question, what technique is very relevant and what is a suitable tool that we can use. But I would say it's very important for us who are supply chain practitioners to be at least with Excel. Get to know properly Excel, and you can learn it online and all those kind of things. So let us make sure that we enrich our skills. So in terms of technology, what I can say is that as of now, you can never talk of data analytics unless you have technology. So technology is an enabler, and what I can say is that even the information system, the logistics information system that we have, these are technology based. So they're actually collecting a lot of data. So what we are missing actually, and this is what I wanted to discuss of my slides, is that we are missing the system thinking in terms of these existing systems, information system that we have in the health sector. So you have the logistics system have its own information, but also healthcare delivery, they have their own system, multiple systems, and these systems are not communicating. So we want this, what I would say, the best is to have these systems communicate, but we can also standardize some of the parameters so that they can be able to be captured properly in each type of the system. Yeah.
Thank you, Dr. Gladys. Thank you. I'm afraid we can't take any further questions as of now, but like I said earlier, while we are grateful that plenty of questions have been asked here, we also encourage that when the video and the slide is posted on the IAPHL listserv, I encourage us to send in our questions in the following mails. and Professor Andy will be there to respond, and so many other experts in the house will be there to respond with real life experiences and provide tools that are necessary for us to move ahead. It will also be posted on the social media for us to continue to engage on the go. I want to say thank you very much to Professor Andy Barakloy of the Empower School of Health for the very immersive presentation that he provided to us, especially leaning back into 30 and more years of experience in public health across 40 countries around the globe. So I want to say thank you. Then again, I want to say thank you again to Dr. Gladys. We had to stop Dr. Gladys last time because time was against us, and she was gracious to come back again to continue the presentation. And unfortunately, time has gone again. We couldn't conclude it, but the conversation continues. What I would say is that we will find a way of bringing Dr. Gladys on the platform so that she can also have a real-time response to some of these questions. Ladies and gentlemen, I will implore us to just give a hand to Professor Andy and Dr. Gladness on the chat box. Please just give a round of applause and show them some gratitude. Thank you very much. We really appreciate. And we also thank the Empower School of Health for being gracious with this collaboration and bringing forth these resources to our community. Thank you so much. So I will leave the floor for now for Sonia of the Empower School of Health to provide some information around what we have coming from Empower School of Health. Sonia.
Thank you, Timmy, for your support to make this happen again. Thank you, Professor Andy, for his presentation. Thank you, Gladness, for your time and your presentation. We will be surely having another session just with you, so you can deliver the rest of the slides also and to add on it on the same. Rest, the certificate link has already been posted on the chat box, so I would request all to please download your certificate. After post-webinar, the slide deck and the recording and the certificate link will be shared with all. And I'm really glad with IAPHL for their continuous support, and we will be having a session like this in near future also. There is one last poll which is pending, so I would request my backend team to please launch this poll second, and I would request all attendees to please participate on the same. And for any upcoming courses and the existing courses which we have, I would request you all to please visit our Empower School of Health website. To join IAPHL country-wise chapter, I would request to please visit the link that will be posted by Timmy on the chat box. So that's all from my end, Timmy. Thank you. Thank you all.
Sorry. Thank you, everyone. Thank you, Sonia. For this time. We will launch the poll now. Then I will also share the link for IAPHL to the IAPHL website for us to join. Please, while we attend to the poll, I will bring up the link for us, just to let us know that the conversation continues, and many other conversation will continue on the IAPHL itself. The IAPHL is the global community of practice of 8,000 plus membership across 152 countries and counting. And we have country chapters present now in about 33 countries, and we are making efforts to decentralize the operation as much as possible to bring whatever we do to context. So I encourage us to join the platform. I have shared the link. You just click on the link and it takes only about 45 seconds for you to join the platform. We have experts across the supply chain network from the last mile to the very high strategic level at the global scale on the platform, where you can leverage on the expertise of your colleagues from around the world to make the work that you do easier and better. You have access to myriad resources from different implementing partners, and technical forum like this we happen at different times. And by plan, we'll be having this kind of webinar on a routine basis at least once every month. All right, ladies and gentlemen, you have been gracious with your time. We have taken another 25 minutes out of your time, and it's our pleasure to have you always. And we'll also strive to always give you the best that we encourage the work that we do and make the impact that we are hoping to have more in depth. So ladies and gentlemen, thank you. And it is over for now. Sonia. Again, I want to apologize for a lot of us that were not able to ask our questions. Rahel, I recognize your hand. Please pardon me, pardon us. We're going to have you on the IAPHL listserv. Just indulge us and we will attend to every questions. And of course, we will still have other forum like this. Thank you, everyone. Thank you, Alexis. Thank you, Precious, Robert, Chan, Hassan, Marie, thank you, Dennis, Mohammed, thank you, Fage from